Hi, Dr. Garima here, and we are back with our mock session recordings. So this is mock 14. This is a September question paper, September 2022. And we already recorded sessions for question number 1 and 2, which I have already put up on the YouTube. All the enrolled candidates have the link. For the non-enrolled candidates, I will display it just for a week and then I will take it down. So for the new people who are watching this video, this is how an exam question in ABC exam part 1 written would look like. You'll have a main scenario and you will have 5 sub questions. So the more marks you solve, the more confident you become. So anyways, let's see how to solve a mock first of all. This is basically the exact exam question. So you are seeing a 30-year-old, this is SBQ3. Today we are going to solve SBQ3, 4 and 5. So you are seeing a 30-year-old patient with schizophrenia, epilepsy, and needle phobia. Was accompanied by his daughter. Now in the bracket, it's written the carer. It does not mention legal guardian. Okay. Now, whenever a patient with some psychological problem comes and you feel that the patient is not the appropriate person who can give you the correct information or can make a decision about himself, for whatever you do, you need to take the consent from the legal guardian, not the person who's accompanying that person. You understand? So don't get confused just because the question says that the daughter has come. She may not be the right person to give clearance for the actual patient. Patient seems agitated. He has intellectual instability. It is difficult to obtain any information from the patient regarding his history and medication. So you ask for help from his carer during the appointment to get the patient's medication list. Patient is taking antidepressants and antipsychotics. Alright, so this is the main question. Let's see what is the sub-question. You judge that the patient is not capable of giving consent for the treatment. Who should provide consent? Carer? No. Carer can be anyone. In this situation, it was a daughter, but it can be maybe just a nurse. Doesn't mean they are, allowed to give the consent. You should always be going after the legal guardian. Next of kin? No, not again. Because next of kin can be various people in the family. It can be a wife, it can be a daughter, it can be a son. But one person is the person who has to be appointed as a legal guardian. So that should be your answer, not the family member or the carer or the next of kin. Okay. Patient is needle phobic and asks for nitrous oxide minimal sedation. What would you say? See, first of all, the patient is schizophrenic. He's already agitated and he's also needle phobic. And he's on antidepressants and antipsychotics. See, when you have such a patient, you just don't know how they will react. And when they react, they can be like very dramatic, as in they can move their hands, legs, the entire body. They can do anything with their body basically because they don't know what they are doing. You cannot hold such people down, and it can cause injury to yourself and the patient if they particularly have phobia of something. So the best thing for such patients is to treat them under general anesthesia. Let's see what the options are. Nitrous oxide is best indicated under these circumstances. Absolutely wrong. The patient is already taking antidepressants and you want to give another sedative option. The not a good idea about it. You can use nitrous oxide but inform the patient that you still need the needle for the LA. No, nitrous oxide is not a good option again in this because you don't know how the patient may react. If suppose he accidentally or intentionally removes the mask from the nose and there is high dose of nitrous oxide that was being given, you cannot control the patient back and put the oxygen again. There can be chances of diffusion hypoxia. So nitrous oxide is out of the question only. Prefer to perform the treatment under GA. True. Suggest IV sedation. IV sedation, well, it's not a bad option, but in IV sedation, you cannot control the depth of the sedation, and in IV, you don't give intubation basically. So you have to constantly make sure that the chin of the patient is a bit elevated as the tongue falls back. And if the patient just wakes up in the middle of the procedure, which happens sometimes in the IV, it's really difficult to control the patient. So IV sedation is not a good option again. So the only better option out here is to prefer to perform the treatment under general anesthesia. I've given a nice explanation out here. You can pause the video and read it. You have to extract 1, 1 and 2, 7. So that's the front central and the left second molar. All the rest of his dentition are present. What would be the best treatment to manage the edentulous space? Good question. What is the key word here? Best treatment. It is not asking you what the patient wants. It's saying if there is an edentulous space, what is the best treatment for this patient? Now, this patient is not having any blood disorder. All he has is epileptic attacks. So when you have epilepsy or you have a person who is on antidepressants and antipsychotics, you don't want to give him something that can be removed easily from his mouth because, in any of the attacks, he can crush that thing, he can accidentally swallow that thing, it can get stuck in his throat. You want to give something which is very, very fixed. That can either be a fixed partial denture or an implant. Now let's see what are the options here. Implant, okay. Acrylic RPD. Acrylic RPD is something which he can remove or he can accidentally crush and break in his mouth due to vigorous biting motions. He can lose it somewhere as he's schizophrenic. RPD doesn't matter from which material, acrylic or cobalt chromium, so both are out of question. No replacement is also a good option, but here what is the question? Best replacement. Basically the question is asking what is the ideal treatment for an edentulous space. That is what it is asking. Hence the answer implant. If there was a fixed partial denture, even that could have been a good option, but they have not given that. I have only 4 options because that is what I could get from the candidates. I don't know what the 5th option was, but in case in your exam you get some other 5th option, the question would be pretty clear and pointing you out to one option which would be correct. So have a good look at it. Next. The daughter called afterwards and advised that due to financial issues, they cannot go with the restoration plan. So example, you told her, you know what, you should go with the implant, that is the best option for you. But now the daughter has called and she says that you cannot go with the implant option because they have financial issues. So what would you do? See, whenever a patient is telling you that they can't afford a treatment, you have to be very empathic. You should not be making fun of them or making them feel that they are not fit for the treatment or they should not come back to your clinic because they can't afford it. So you should give them either an installment plan or you can very politely tell them, we understand your situation and we can give you a suggestion that you can visit the community health centers or the Australian government centers where the treatment can be done. You should never tell the patient, oh, because you can't pay now the treatment cannot happen only. That is very rude and you're not supposed to do that, and that is very unprofessional as well. So here this question is important because it can also be asked in your part 2 exam. Your ASCII Viva is going on and the patient says, I can't afford. So you cannot just say, oh, I'm so sorry now. Then you should stay in pain or something like that. You can tell them, like, we're sorry, but let me see how I can help you with that. You should always be helpful and give solutions and suggestions so that the patient can choose. So here the options are: explain to the daughter the health impact of not continuing with the planned treatment. You should also not scare the patient saying, oh, if you can't get the treatment done because you don't have money, then this is what is going to happen, which will be more bad for you. You should not be doing that. So option A is not a good option. Report abuse. For what? There is no abuse out here. Suggest a payment plan. That's a good option. refer the patient to the community dental clinic. That is again a good option. Now, depending on what the question is, you can choose any of these two options. Now, here both the options were correct, so they are there in the answer. But in the exam, you may have a very specific question pointing you directly to the right answer. So you can suggest any one of these actually. Now, what oral conditions would you expect to see in this patient? See, he's taking antidepressants, antipsychotics, he's having epilepsy, he's taking some drugs for that. What does all these drugs do? They will cause gingival hyperplasia, 100%. So that should be your answer. Now, next question is SBQ4. A patient has HIV. One HIV question will surely come in your exam. So make sure you study in and about it. You should study how HIV happens, what viruses are responsible for it, what are the oral signs and symptoms for HIV, what precautions you are supposed to take in an HIV patient, what tests you are supposed to do, what signs you are supposed to look after, what are you going to tell the patient, what are you going to tell the staff, all these things, write it down, make your notes, revise it. Understood? So, yeah, a patient has HIV, requires extraction of 2-5, that's the left upper second premolar. He said he has latent pulmonary tuberculosis. The key word here is latent. What does latent mean? Latent means that there are TB bacteria present in his body, but he's not in an infectious stage, meaning he's not going to spread TB. He's not in an active stage of the disease. So basically, an HIV patient with latent pulmonary tuberculosis shows you his latest MON2 test positive. MON2 test is what? Basically, you inject a small ml of tuberculin on your arm, and if a bump comes around it, it means that you have TB bacteria in your body, but you're not active. You're not an infectious person. You just have those bacteria in your body. Now, he's also taking rifampicin, that's a medication for TB, for 2 months and has to continue for another 2 months according to his doctor. That's your main scenario. First question. The dentist decided to work with standard precautions, but the nurse was apprehensive, so the dentist checked the immunization status of the staff for TB. All are vaccinated. His reason for choosing standard precautions. Basically, the question is saying that why are you choosing standard precautions and not, some extra add-on to it? That's because he's having latent TB, which means that he's not infectious. So you can choose standard precautions. You don't have to, go the entire coronavirus PPE kit, like completely covered like an Ebola virus type of situation. You can just keep on using your standard precautions because he's having latent TB. If it was active TB, then the situation would have been different. Now, after the procedure, how will the dentist dispose of the waste? Meaning there was infected waste. If you are treating a patient like a normal standard patient, you should also take his waste as a normal standard patient. You have already discarded the tooth as per local regulations. How will you segregate the rest of the waste as? Hazardous is like some bioactive thing going on, which is not the case here. General, you can't. This is not a general waste. This is a medical waste. Sharp is, if there is sharp, you have to dispose in a sharp container. So this will fall under the medical thing. See, regardless the patient is having TB or not, you should believe as if every patient is having some problem. And you should maintain your standard precautions in general, unless specifically the patient is giving you a particular history. That's for your own safety, your staff safety, okay? Because sometimes even the patient wouldn't know if they are infected with a disease because they may not have any signs and symptoms. Third question. The dentist had got hepatitis C 2 years ago. He was treated for it and got RNA test negative after 12 months. That is 1 year ago. So 2 years ago he had a problem and 1 year ago he got that everything is clear. What should he do next? See, this question is nowhere related to this scenario. It could have been asked you practically in any other possible scenario. So this is testing your infection control knowledge. Tell the patient about it before performing extraction. See, if you had a particular disease, you as a dentist, and then you got clearance from it, why do you need to tell the patient? You won't be telling every patient, oh, listen, I had hepatitis C, but now I'm clear, so I'm going to do your extraction. Why? Why do you want to scare somebody? No, you won't do that. Take clearance from medical professional for exposure-based cases. Yeah, that's true. The only person that should know that you had a problem and then you're clear to practice is your medical practitioner. So take a clearance for him saying that, okay, you know what, I'm going to do extraction of so-and-so patient. Am I clear to perform it? He is the correct person to tell you about it. Keep documented 12 monthly antibody report on hepatitis C. Keep documented where? In patient's file? No. You just need to take your clearance and you just need to keep it in your file. That's it. Tell another dentist who has immunity to treat this patient. Why would you send your patient to some other dentist when you can treat it yourself? And how do you know that the other dentist has immunity? How do you know that he himself did not have hepatitis C and is now clear? No, that is not a correct option at all. It's just these options are to confuse you. Don't get confused. You should not perform exposure-prone procedure on HIV patient. Why? The patient is having latent TB, his HIV is pretty much in control because the question is not mentioning that you can't perform. So you're treating him like any standard patient. So you should go ahead and treat. The right answer is option B. While doing his oral examination, what will cause you to alert his general practitioner? So you're examining a patient who has a history of HIV and now you see something in his mouth. So what would cause you to be alerted about it? Hairy leukoplegia. Yes, that's the right answer. Melanotic macule. It's not a wrong option, but mostly HIV patients more frequently are affected by hairy leukoplegia than melanotic macule. Lichen planus. Lichen planus can happen to anybody. Leukoplegia, again, it's a precancerous condition and you should be worried about it, but it doesn't happen that much often as hairy leukoplegia. Like hairy leukoplegia somehow is more common in HIV patients and it may be innocent, but it can be harmful. So you should be telling his GP immediately about it so that the GP then takes some action against it. Now, on which basis will you decide that the tooth will go for normal extraction or by standard aseptic non-touch sterile technique? Now, what do you mean by normal extraction and standard aseptic non-touch sterile technique? See, under normal extraction, you touch the blood and everything of the patient, okay? And standard aseptic non-touch technique, I think you wear 2-3 pairs of gloves and you try to make sure that there is minimum bleeding that is happening, as you know, you will be trying to more and more elevate probably or just remove it with the forceps without probably reflecting the gums or something. That is what my understanding from this question is. So, but what would make me decide that? See, that would be decided in any HIV patient with just the viral load. Viral load meaning if the load of the HIV virus in the body is less, that means the patient has better immunity to handle everything, and you, even though some injury happens, won't be that much at a risk of contracting the virus. But if the viral load was really high, like the patient is, you know, just full of infectious stage of the virus, and then if an injury was supposed to happen, God forbid, then you are more likely to contract that disease. So the only thing that would make sure or minimize the risk of the procedure is the viral load. Platelet count, he's not having any blood disorder, but it's good to check. Take X-ray before. X-ray is not going to tell you anything much about the viral load, but yeah, it will definitely tell you how complicated the extraction is. Dentist hepatitis C level, no. Your level has got nothing to do with it. So the viral load becomes the right answer. Read through the explanation properly so that you understand more. The last question of today, COVID. I don't think so any more COVID questions are going to be asked. In my own exam, it was not asked because the COVID stage had long passed. It was 2020. No more COVID. Once in a while cases are coming. But yeah, you're supposed to know. But yeah, but in the September paper it was asked. My March paper it was not asked, but the September paper was asked. So might as well you know the guidelines. All those people who have enrolled in my course, I have given them a big, nice, colorful table format of COVID guidelines. So it's very easy for you to remember. Like in stage 1 of COVID, stage 2 of COVID, stage 3 and stage 4 lockdown of COVID, what you can treat, what you cannot treat, how you're supposed to behave, what precautions you're supposed to take. Okay. So anyways, read that before answering the question. But let's answer this question anyways. So level 1 restrictions are going on. A patient called the clinic, your clinic, and the patient says that she was exposed to COVID-19, but she's still waiting for the PCR result. Currently, she wants appointment and is concerned for a swelling in the mouth. See, the patient here is not saying that it's urgent, neither is she saying she is in pain. She just says there is a swelling. Now, how would you manage? If the patient would have said like she's febrile and she's in too much pain and there's big swelling and she can't swallow, breathe, blah, 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 then you should have immediately asked her to go to the emergency department of the hospital. But since the patient has not mentioned any of these, you tell her that we will defer the treatment until your results are obtained. Understood? Telehealth consultation is not a wrong option, but sometimes you may not be exactly able to see the swelling if it's really at the back of the mouth. But even to examine, you would be like, first get the result, because if you're actively down with COVID, then you would probably again referring to the emergency department of the hospital. The rest of the options are not applicable. In such situations, the use of pre-procedural mouth rinse is recommended. What is a pre-procedural mouth rinse? It's basically when the patient comes, before you even ask them to open their mouth to do an examination, you will tell them, please take this mouthwash, rinse your mouth and then sit. So, when would you use the pre-procedural mouthwash? Or on whom would you use? So here the option A is correct. You'll just ask the patient. You don't have to ask the patient and your staff and yourself. Post-procedural, what is the point of asking the patient to rinse after the procedure is done? It might as well be before the procedure. So again, the rest of the options are like for the patient and the staff, pre and post. No, just the pre-procedural for the patient. That's it. Which mouthwash can be used? Always chlorhexidine, 0.2%. Hydrogen peroxide, 10%. Wow, your mouth is going to be on fire if you do that. Povidone iodine, not a bad choice, but 20%. No. Essential oil mouth rinse. You don't know which essential oil would you be using. And you don't know the antisepticness of it. But chlorhexidine is scientifically recommended. It's available. You'll be asking them to do so. Not recommended in the guidelines. No, the guidelines don't mention that. Neither it is mandatory to use, but 0.2% chlorhexidine is a good choice. I have given again here a good explanation for it. See, povidone iodine solution is 0.23% to 1, and in the option it was 20%, which is like huge. Now, if the patient has some disability to perform her procedural rinse, what variation would be applied? Now, suppose the patient says, I can't rinse my mouth, I don't know how to rinse or whatever. Okay, fair enough. Then what you can do is you can just take a gauze and you can dip it in the mouthwash and then you can swab her entire oral cavity with it. The rest of the options are not applicable. Avoid the procedure. No, why do you want to avoid the procedure? Non-aerosol treatment. No, that's dental treatments are always having aerosols. Use of triplex syringe and high vacuum suction. What, you'll spray water? No, not needed. In fact, that would generate more aerosols. Rinse with water. Well, she said she can't rinse. So using a swab of mouthwash and a gauze makes the right choice. And the last question of today. Other patient has to get treatment generating aerosol. So there is another patient who has to get treatment generating the aerosol, which can't be deferred. Probably it's an emergency. Then what you should do? Well, you should use an N95 mask. So basically, this question is saying that there is another patient probably affected by COVID or something, but it's just level 1 restriction. And you need to do the treatment generating the aerosol. So you use an N95 mask. Have you used an N95 mask? It's horrible. You can't breathe through it. But yeah, you have to use that. The option A, use TGA approved disinfectants after treatment for all surfaces, is not wrong, but then you also have to use detergent, which they have not mentioned. So hence I will go with the N95 mask. So that's about it. We have 14 such questions. We have finished 5 of them. I'll shoot another video with another 3 questions sometime later. Till that time, read this, understand this, pause this video, read more about it. For all those new people, yes, this is how ADC exam looks like. There are 280 questions for your exam, variety of questions. You should use your analytic skills to answer them, okay? Thank you. Bye-bye.